Spirometry, is it important? Can you do it in the office-based setting? These questions and more will be answered today as we discuss spirometry. So join me, shall you? Before we discuss spirometry, we have to do a review of obstructive versus restrictive lung disease. Let's drop some anatomy just real quick. When we inhale, our intercostal muscles retract, our ribs move out, our diaphragm contracts, and it pulls downward. That brings air in. Air moves from higher pressure, atmospheric pressure outside the lungs, to lower pressure inside the lungs. It essentially gets pulled in. Hence, inspiration is largely dependent upon muscles and the ability of the lungs to expand. So restrictive lung disease is anything that presents as difficulty for the lungs to expand, for the lungs to take air in. Restrictive lung disease is defined as extrinsic or intrinsic, but no matter if it's extrinsic or intrinsic, it is an inability or a decreased ability for the lungs to inhale, for the lungs to bring air in. Now, extrinsic is outside the lungs. The lungs are fine, but there's something outside of the lungs that is preventing them from fully expanding. That can be a chest wall deformity like kyphosis or severe scoliosis. Kyphosis is hunchback. Neuromuscular diseases like amyotrophic lateral sclerosis or Lou Gehrig's disease, Guillain-Barré, myasthenia gravis, muscular dystrophy. A depression of the respiratory center, that would be secondary to either trauma or drugs, like opioids, benzos, alcohol. Marked obesity, that has to be severe obesity to the point where there's so much adipose tissue packed into the body that it compresses the lungs. Severe congestive heart failure, that's due to fluid overload. Intrinsic restrictive lung disease means it's inside the lungs. There's something wrong with the lungs themselves that is preventing them from fully expanding during inspiration. That can be certain occupational things, like breathing in asbestos or silicosis. That can be autoimmune disease like lupus or ANCA-associated vasculitis. Idiopathic pulmonary fibrosis, scarring, and fibroids on the lungs. Remember, idiopathic means, I don't know. You know, our physicians, nurse practitioners, PAs, we're not going to say, I don't know, so we say, no, it's idiopathic. Sarcoidosis, I have an asterisk by that. Sarcoidosis is granuloma formation with hilar lymphadenopathy. It can also be obstructive. Let's go back to anatomy. When we breathe out, we exhale, our intercostal muscles relax, our diaphragm relaxes, and our elastic fibers recoil. Air is forced out of our lungs when higher intraalveolar pressure forces air out into the lower atmospheric pressure. But if the bronchioles or bronchi are inflamed, if they're narrowed, if they're filled with mucus, air will get trapped, and that is obstructive lung disease. So in obstructive lung disease, the patient has difficulty exhaling the air. It's getting trapped. There's something impeding the progress back into the atmosphere. We have acute stuff like bronchitis or pneumonia, but more serious and more pertinent to this lecture, COPD, asthma, cystic fibrosis. I'm going to hold off on the FEV1 FVC ratio until a few slides down the road, so hang on to that. So pulmonary function tests, there are many, and spirometry is just one example of a pulmonary function test. Spirometry is what we're going to focus on in this lecture, and spirometry is the one that you can do in your office-based setting. You can do exercise challenge 2, you can do 6-minute walk test, but for the most part, all of the other ones apart from spirometry are going to be done in a pulmonary office. They're more specialized tests. But let's focus on spirometry. When would we order it? What even is it? Well, it's a measurement of the amount and speed of air that the patient can exhale. So we would order it if we want to work up a patient for dyspnea or cough, abnormal chest imaging, maybe to guide treatment in those who we know already have asthma or COPD. Generally, patients at the age of 6 and up can do spirometry, but it's dependent on the child. Some 6-year-olds can't do it, some 5-year-olds can do it. There's no set age limit. Let's just fire through the other ones real quickly, but we're going to stop on when we get to methacholine challenge. Lung volumes, that's the measurement of the actual volume of air within the lungs. Spirometry cannot do that. Spirometry just measures the force of exhalation. Lung volumes actually measures how much air is in the lungs. Gas exchange testing, the extent that oxygen passes from the alveoli to the blood. Muscle pressures, the pressure generated by respiratory muscles. So that may be ordered to evaluate a neuromuscular disease. Oxygen titration test can be used for those who have oxygen. 6-minute walk test, how far can a patient walk in 6 minutes? It provides an assessment of functional status, but it's not a diagnostic tool. Methacholine challenge test. In the methacholine challenge test, the patient breathes in a mist of methacholine. Now, some super specialty clinics use histamine and other things, but by and large, the most common medication used is methacholine. And methacholine induces bronchoconstriction through agonist activity on the M3 muscarinic receptors within the lungs. It's breathed in, so it stays in the lungs. It doesn't cross the blood-brain barrier. It doesn't go into the GI system. It stays in the lungs. Asthmatics who have a pre-existing airway hyperreactivity already will react negatively to lower doses of methacholine than the normal, healthy, non-asthmatic will. So with the methacholine challenge test, we are actively trying to get the asthma patient to respond negatively. And at low doses, the patient will have shorter breath, cough, all that. So it is reversed with albuterol. But this is a useful test for someone who has situational asthma. Let's say the patient just has asthma when they run. Well, when they come into your clinic, odds are they didn't run to your clinic. So they're going to be normal. So the spirometry test can be normal. That's where the methacholine challenge test can come in handy. Or also available is the exercise challenge. That's where the patient exercises on a treadmill in lieu of methacholine. So the patient would do a baseline spirometry, then either hit the methacholine pipe or jump on the treadmill, and then repeat the spirometry. So why do we even care about spirometry? Well, that provides a definitive diagnosis and staging of obstructive lung disease. We're going to talk about the FEV1 to FVC ratio. That's what we use to diagnose someone with asthma or COPD. And then we're going to talk about the FEV1 by itself. That's what we use to stage both of those. So it really, really can help, and it aids in the diagnosis of those restrictive lung diseases too. Are there limitations? Yeah. Pulmonary infections are an acute obstructive illness. If someone has bronchitis or someone has pneumonia, that's not the time to do spirometry because of course it's going to be abnormal. Smoking can obviously affect it too. Now that's more so in younger patients, social smokers, white smokers. They may smoke 1 cigarette a day. Well, if they're smoking 1 cigarette a day, make sure it's not before their spirometry test because it's going to affect it. Now, your average smoker who smokes throughout the day, that is the average for that patient. So, that doesn't really affect it too much. It's just for light smokers. Plus, a limitation is asthma has variability in clinical symptoms, which we talked about. Exercise-induced asthma can be hard to diagnose on a spirometer unless the patient ran to your office and you immediately hook them up to the pipe and check their spirometry. Risks, dizziness, the patient is exhaling as hard as they can for as long as they can. It can make people dizzy, so it's done sitting. And because of that, there is an exertional component to spirometry. So if someone has unstable cardiovascular health, like they just had a heart attack, we don't want them to have another one while we're assessing their lung function. So let's wait a little bit on spirometry if they just had that heart attack. Here's what it looks like. This is an office-based spirometry. Now it can be as cheap as you want it to be. Office-based can run, $200. Or you can have the full-on get-up where there's a whole lab and the patient goes into the specialized cell with a huge computer outside of it. They're both spirometry, but there is different levels of spirometry. But in all of them, the patient is going to sit. It's best if they can have a nose clip on because we want to assess the air that's coming out of the mouth, not out of the nose. Some patients can't tolerate that. Children can't tolerate that, so it's not always done. But the patient performs a deep inhalation, puts the mouthpiece in their mouth and blows out for at least 6 seconds. And then that is followed by complete inspiration. 3 maneuvers usually are performed unless one of the efforts is lacking, and then it can be more. But we want at least 3. We want to take the average of those 3 efforts. Now, different spirometers provide different layouts and different components to the actual printout. So what you see here may not be what you see in the office that you will work. But let's go over the components. Every single spirometer will print out a chart. And that's what you see at the top. FVC is forced vital capacity. That is the maximum amount of air exhaled from a position of full inspiration. So the patient breathes in as much air as they can and then blows out as much air as they can. How much air can the patient blow out of their lungs? That's forced vital capacity. FEV1, that's forced expiratory volume in 1 second. That is the maximum amount of air exhaled in the first second. In healthy people who have healthy lungs, I should say, around 75% of the forced vital capacity is exhaled within the first second. So those of us who have healthy lungs, we blow out 75% of the air in our lungs within the first second. And that's because after we inspire, after we take in air, the airways are pulled open and there's a high volume within our alveoli and a high pressure there. And when we start to breathe out, that pressure is released. Now on this patient, we have his predicted, we'll start with the FVC. We have his predicted FVC. That is based off of data from the National Health and Nutrition Examination Study. It was a nationwide sample of nearly 40,000 people across all different ethnicities. And it was carried out by the American Thoracic Society and the European Respiratory Society Task Force. And it takes into account age. When we have our growth spurt of puberty, we have an increase in lung volume, and then throughout adulthood, that gradually diminishes. Sex, males on average have larger lung volumes than females, and so for spirometry, given we want the most accurate results, we use the birth sex. Height, taller people have larger lung volumes. But again, we want the most accurate results, so don't rely on the patient's stated health. This is a time to actually measure their height in the clinic and then perform the spirometry. Weight doesn't play as large a role in pulmonary function for the average person. So some spirometers want you to put it in, other ones, they don't really care. But again, you can see that the patient's results are going to be compared to those of the average healthy person of this same demographics. Let's go back to the chart. We have LLN. Not all spirometers use LLN, but for those that do, it stands for lower limits of normal. What value would the patient have to get to define as abnormal? So this patient would have to have an FVC of 4.34 or lower to qualify as some sort of abnormality. Then we have his actual number, and that is an average over the 3 efforts. And then we have percentage. So we take the patient's actual, which is 5.18, divided by the predicted, which is 5.20, and we get 99%. Notice we have pre and post bronchodilator. So the patient does the baseline. That's with no albuterol in the lungs. That's the baseline. Then the patient does anywhere from 2 to 4 squirts of albuterol over 10 to 15 minutes. In most cases, the patient takes a hit, waits 3 minutes, takes another hit, waits 3 minutes, takes another hit, 3 minutes, takes another hit, and then you can do the post-bronchodilator spirometry. We also have FEV1 over FVC. That is the fraction of the forced vital capacity that can be exhaled in the first second. It is used to determine if the patient has obstructive lung disease, but it's not used to gauge the severity of that obstructive lung disease, because the FVC tends to decrease as obstruction increases. So to gauge the severity, we're going to look at FEV1, and we're going to do a lot of case studies. On the lower left, you see a flow volume loop. This, again, is not always included with every spirometry. Some just have the expiratory part. But the inspiratory and expiratory flow is the y-axis, and the volume is the x-axis. Red is before the bronchodilator, green is after. So let's start with pre-bronchodilator, which is red. In this specific one, the x-axis is counting down. In some spirometers, it counts up, but we're going to start at the lowest volume. So pre-bronchodilator, that for this patient is 2. Notice the red line does not go any lower than 2. So the patient's residual volume is 2 liters. When we exhale, we retain some air. We don't blow it all out. This patient theoretically is retaining 2 liters. Then the patient breathes in, and that is the lower slope, because the y-axis is measuring the flow of air away from the lungs, the flow of air when the patient exhales. So if the patient is inhaling, it's going to be negative. So we're below the axis as the patient is breathing in. And then as the patient quickly exhales, it shoots way up to 14 liters per second. That's going to be, right around the max effort, and then it's going to peter down. So let's go back to this. Let's do pre-bronchodilator. We established the patient's residual volume is 2. What is the patient's total lung capacity? How much air can the patient's lungs theoretically hold? It's right about 7. So what is the patient's forced vital capacity? 7 minus 2 is 5. But in actuality, spirometry cannot determine the residual volume or the total lung capacity. You would need to refer to pulmonary specialty for the lung volume test for that. Let's look at the volume time curve, which is in the lower right. And again, we're going to do a lot of case studies here. That is the volume per each second of how much air is being exhaled. So notice most of the air gets exhaled again within the first second. Let's go back to that flow volume loop. Normal, we have black. Obstructive is green, and that's the one on the far left. Restrictive is blue, and that's on the far right. Some people like to remember restrictive by restrictive will be right of normal. So notice normal is black, and then restricted is to the right of that. Restricted starts with an R, to the right of normal. But we're going to go into why we see that. We want to know why is it to the right of normal. And then airway obstruction is purple. That's the small one. So let's start with obstruction. Air trapping occurs with obstructive lung disease. And we're going to see either normal or slightly reduced inspiration. But in most cases with obstruction, inspiration is not significantly affected. It's exhalation that is affected, breathing out. So in this example, inspiration is slightly reduced. Notice the black, which is normal. Inspiration is reduced. And then the patient blows out some of the air, but has a large residual volume. They have a lot of air trapping. They're not blowing it all out. Because of this, there is a concavity to the pattern. Notice how it slopes. Again, we're unobstructive, we're on green. Notice during exhalation, there is a sloping, a concavity. It slopes inward. So when you see that, even without looking at the chart, now we'll always look at the chart, but you should be able to see that concavity and be like, this guy probably has obstructive lung disease. So again, two things you're going to look for: the concavity and an increase in the theoretical residual volume. What about restricted? Let's go to blue. Restricted patients have nearly normal to normal expiration. They don't have problem getting the air out. They have problem getting the air in. So there is a shallowness to the inspiration. The top part is relatively normal because, again, they're breathing out just fine, but there is a shallowness to the inspiration. Plus, there is a shift to the right because there is less residual volume. Less air coming in means less air going out. There's no concavity because there's no problem with exhalation, but on the top part, you see that peakedness, that narrow peak, which resembles the normal flow volume loop. So if you see shallow inspiration with a peaked, relatively normal looking top part with no concavity, think restriction. And then the airway obstruction, the purple one, there's decreased inhalation and there's decreased exhalation. Something is blocking the airway passage so that air cannot come in and it cannot go out. Cancer, a goiter, tracheal stenosis, that's tracheal narrowing due to scarring following intubation. As you can imagine, airway obstruction, when you see that, that's not good. And we'll do a case study or two on that as well. Here's another way to look at it. Normal, nice big dip of inspiration followed by almost straight up as the patient exhales most of the air within the first second. Notice with COPD, there is a prolonged residual volume. And then there is concavity because the patient has air trapping. They're not getting most of their air out within the first second. They're continuing to blow, continuing to get it out. And then the third one, interstitial lung disease, that's a type of restrictive lung disease. Notice how it's narrowed. Less air in means less air out. It's narrowed, it's peaked. This one has a little bit of concavity, but not to the extent of obstruction. And then this is the volume time curve. Notice in a healthy patient, again, this is volume per time in seconds. The first second in a healthy patient, most of that air is coming out, and then not much more comes out thereafter. So for this patient, in 1 second, in the first second, he's blowing out 4 liters of air. And then after that, he's just blowing out another liter. Notice the patient with obstructive lung disease. The first second, he's blowing out 1.8 liters, and then he's continuing to blow it out. So there's a ramping effect. He's still blowing. It takes a whole lot more than 1 second to get his air out because there is obstruction and it's getting trapped. So here's a question for you. What would the volume time ramp look like for a patient who has restriction? That's right. It would be pretty much like a healthy patient because they don't have that much trouble blowing air out. It's getting air in. And here's just another example of the results you may get from a specific spirometer. Notice you get the chart, you get the time ramp, but then with the flow loop, it's only the expiratory phase, and the x-axis is ascending instead of descending. But that's okay, because we put all of these together. We don't just look at one component. And honestly, for the most part, it's going to be the chart that gives you the most information. Now, the first thing we have to do is make sure the patient is actually giving us maximal effort. Remember, we use spirometry to actually diagnose someone with obstructive lung disease. So if they're just kind of, whatever, well, that can certainly give them a diagnosis that they don't actually have. So we need to coach the patient. We need maximal effort. You can have the most expensive spirometer known to man. It's not going to matter if the patient doesn't even try. So it's not so much the expense of the equipment, it's the effort of the patient. So phase 1, coach the patient to inspire as deeply as possible after a few normal breaths. And then phase 2, tell them blow, 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 keep blowing, keep blowing, keep blowing until you get to 6 seconds. Wait a few minutes and repeat for 3 efforts. There's some medical techs that do this, and they put their all into it. You can hear them down the hall coaching their patient, blow, 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 keep blowing, keep blowing, keep blowing. And you're like, okay, that's going to be maximal effort. I'm like what I'm hearing. But let's look at the chart or the graph or whatever on the left. A, the red one, is hesitancy. Notice the patient takes a real quick breath and then they breathe again. So it's like, that's not what we want. B is blue. That's just poor effort. Notice the FEV, there's not even an FEV1. I mean, it's just a slope. That patient isn't even given a whatever about anything. C is green. That patient is coughing. And then D is orange. That patient started strong and then just kind of gave up. So we want to evaluate that flow loop to make sure that the patient is giving maximal effort before we make any diagnoses. And you can see on the right there, just another way to look at it. How do we interpret this thing? Number 1, look at the flow loop to ensure maximal effort. We want to make sure the patient is giving it their all, but also we look at the flow loop to get an idea of what we're dealing with. Number 2, look at the FEV1 FVC ratio. A normal ratio is 0.75 and above. A healthy person's lungs exhale 75% or more of the air in their lungs within the first second. But when obstruction is present, the ratio is less than 70% or 0.7. We use 70 as the cutoff. It takes longer for a patient with obstruction to blow the air out of their lungs, whether it's due to mucus, inflammation, or what have you. So look at that FEV1 FVC ratio. If it is less than 70%, you're dealing with obstruction. You can diagnose that patient with obstructive lung disease, but which one? Asthma, COPD? Well, the next thing we look at is pre-bronchodilator and post-bronchodilator. Now remember, we can diagnose someone with obstructive lung disease based on the ratio, that's it. But we cannot gauge severity. So we are now done with the ratio. Now we're going to look at FEV1 and FVC separately. All right, so the patient's FEV1 to FVC ratio is less than 70%. Number 2, is there improvement in either the FEV1 or the FVC of at least 12% and 200 milliliters? That's for adults. If it's a child, just a change of 12%. You don't evaluate the milliliters in a child because they have smaller lungs. If there's a change in either the FEV1 or the FVC of at least 12% and 200 milliliters for an adult, that patient has asthma. If there's no change post-bronchodilator, or post-bronchodilator the change is less than 12% and less than 200 milliliters, then that patient has COPD. Because remember, with asthma, there is a reversible inflammatory response in the lungs. With COPD, it's irreversible. Now, what about restriction? Remember, with restriction, air's not coming in, but it's getting out just fine. So the FEV1 FVC ratio will be normal. There's no problem getting the air out. It's getting it in. They can blow out at least 75% of their air within the first second. But what about the forced vital capacity? Less air in will affect that. They're not breathing as much air into their lungs, so there's less air in their lungs. The FVC will be low. It's going to be less than 80%. 80% is the cutoff. So restriction is FEV1 FVC ratio greater than 70% and FVC less than 80%. Let's say you see an FEV1 FVC ratio that's greater than 70% and an FVC that's greater than 80%. What's that? That's normal. Normal, healthy lungs. All right, are you ready for some case studies? I know I am. They have a biblical theme today. We're going to look at biblical patients. Eve is a 19-year-old woman who presents complaining of shortness of breath of several months, denies any cough. So this spirometer provides the results in milliliters, most use liters, but that's okay, we can deal with that. We don't have a flow loop to evaluate. So let's go to the next step. Is her FEV1 FVC ratio less than 70%? No, it's not. She's at nearly 85%. So she does not have obstructive lung disease. Does she have restrictive? Well, is her FVC less than 80? No, her forced vital capacity is 104%. She has neither obstructive lung disease nor restrictive lung disease. She has something else going on, maybe anxiety or there's just something else going on, but it's not either of those lung processes. Samson, 15-year-old male who has shortness of breath and cough that occurs 5 to 10 minutes into his run. He runs twice a week. And these symptoms have been going on for about 2 to 3 months. All right, excellent candidate for spirometry. We have the expiratory portion of this flow loop. Is it adequate? Yes, that's really good effort. Is it normal? Yeah, we don't see any concavity. It's not sloping inward. So the flow loop is not suggestive of obstructive lung disease. We don't see tall, narrow, peakness to it. So it doesn't look like restricted. Is the FEV1 FVC ratio less than 70%? No, it's not. He's at 78%. Is his FVC less than 80? No, he's at 104%. So based on these spirometry results, the patient has neither obstructed nor restricted lung disease. But can he still have asthma? It sounds to me like he has asthma. Yeah, it only happens when he's running. Well, he's sitting in a chair for spirometry. He's kicking back. Well, he should be sitting up straight, but regardless, he's sitting in a chair. He's not exercising. He probably has situational asthma, so what can you do? Well, you have 3 options. Number 1, treat him based on the symptoms. Prescribe him either albuterol or formoterol combined with an inhaled corticosteroid, and tell him use this about 5 to 10 minutes before your run. And if it resolves your symptoms and you don't have shortness of breath, you don't have a cough during your run, we know you have exercise-induced asthma. Option number 2, do an exercise challenge. Now, in most cases, that's referred out to pulmonary, but you could certainly do it in your office. The patient exercises for 15 minutes, get them on a treadmill, crank that thing up, and then have him do spirometry. Now, obviously, you would want a rescue medication on hand should you have an asthma attack in your office. Or number 3, get him in for a methacholine challenge test. So you have some options there. Moses is a 20-year-old male who presents complaining of several months of wheezing, shortness of breath, especially in the morning and with exertion. He experienced these symptoms throughout the day. Okay, we have the exhalation part of his loop. So he has either concavity or submaximal effort, one or the other. Either he's just not really caring, or that looks like mild obstructive lung disease. So let's look at his FEV1 FVC. Is it less than 70%? And we're looking at pre-bronchodilator right now. Is the pre-bronchodilator FEV1 FVC less than 70? Yeah, he's at 50%. So number 2, post-bronchodilator, does he have a 12% and at least 200 milliliter response in either the FEV1 or FVC? Well, yeah. In his FEV1, he increased 45% and 1.05 liters, and his FVC increased 5% and 0.25 liters. So the FEV1 qualifies him to have reversible obstructive lung disease. Which obstructive lung disease is reversible? Asthma. So he has reversible contraction of his bronchial smooth muscles. All right, we're not done yet. We've diagnosed him with asthma. Where does he classify? Well, he has severe persistent. Notice he has daily symptoms, and his pre-bronchodilator FEV1 was 54%. Delilah is 45. She has a chronic cough. She smokes. Let's look at her flow loop. Good effort. She has some mild concavity. Remember, we want that slope to be pretty much straight, and she is sloping in just a bit. That is suggestive of obstructive lung disease. Let's look at her FEV1. FVC is the ratio less than 70%. Remember, pre-bronchodilator. Yes, it is. She's at 67. She has obstructive lung disease. Is there a 12% and at least 200 milliliter change in either the FEV1 or FVC post-bronchodilator? No, there's not. Her FEV1 only changed 4% after she hit the albuterol and repeated the spirometry. FVC only changed 3%. So what is your diagnosis? COPD. That is irreversible. But sit back. Does something not seem right here? She's only 45. Yeah, she smokes. She's been smoking since 17. She was 17. That's still fairly young though for COPD. So you would definitely want to draw an alpha-1 antitrypsin on this patient. That is a serum test. We do that for every COPD patient if we're following the GOLD guidelines. I would also want to check her hepatic enzymes, because if she is deficient in alpha-1 antitrypsin, it can also manifest with elevated hepatic enzymes. And we want to be sure to talk to her about smoking cessation. In order to prescribe the appropriate pharmaceutical treatment to someone with COPD, it's important to have an understanding of how to stage COPD. We use spirometry to diagnose someone with COPD, and for decades, post-bronchodilator values were used to stage a patient based on the severity of his or her COPD. However, there's a weak correlation between the severity of airflow obstruction and the symptoms experienced by the patient. So subjective questioning is now used in conjugation with spirometry results. In my opinion, this is an important shift, as staging is now more individual-based and less population-based. Notice on here, the patient is questioned regarding the number of moderate exacerbations experienced, and that is within the last year. A moderate exacerbation is defined as an increase in dyspnea, cough, and or sputum production that occurs acutely. And that can be due to environmental changes, infection, or no known cause. In addition, the GOLD Committee recommends the COPD assessment test and the Modified Medical Research Council Dyspnea Scale, both of which are found on the next slide. I encourage you to use both, as COPD impacts patients beyond just dyspnea. Category A involves a post-bronchodilator FEV1 of 80% or more, an MMRC of 0 to 1, a CAT less than 10, and not more than 1 moderate exacerbations within the last year. Notice, if there was an exacerbation, it cannot have resulted in the hospitalization of the patient. If the patient was hospitalized, they're automatically in Category E. Category B involves a post-bronchodilator FEV1 between 50 and 79%, an MMRC greater than or equal to 2, a CAT greater than or equal to 10, and not more than 1 exacerbation within the past year that did not result in hospitalization. The previous staging criteria used to have C and D, but in the most recent update, the GOLD guidelines now combine C and D into E. A post-bronchodilator FEV1 of 49% or less, at least 2 exacerbations, or at least 1 COPD-related exacerbation requiring hospitalization within the last year. MMRC of at least 2 and a CAT of at least 10. Now, generally, these requirements align. A patient who scores a 5 on the CAT and has an MMRC of 1 will generally have an FEV1 of 80% or greater. But let's say the patient had a 5 on the CAT, a 1 on the MMRC, and has a post-bronchodilator of 75%. Place them in the less severe category, Category A in this case, because we always want to start low with pharmaceutical treatment and go slow. Don't overtreat. Let's talk specific treatment. There has been an effort to simplify treatment with the most recent guidelines. The goals of COPD treatment are generally symptomatic because these medications have not been shown to decrease mortality in a patient with COPD. Group A, a bronchodilator, either a short-acting or a long-acting one. The long-acting is preferred except in patients with very occasional dyspnea. So you can prescribe a LAMA, LABA, SAMA, or SABA. There are many patient variables at play: availability of the medication, cost, comorbidities. If you do prescribe a long-acting bronchodilator, it is important the patient also has a short-acting available as a rescue inhaler. If you prescribe a LAMA, it is best to co-prescribe a SABA and not a SAMA, so as not to prescribe 2 medications with anticholinergic side effect profiles. Group B, a LABA-LAMA combination with co-prescription of a rescue inhaler. The EMAX randomized trial, EMAX, was a 24-week double-blind study comparing LABA-LAMA combination therapy to both LABA monotherapy and LAMA monotherapy. It was found that the combination therapy provided early and sustained improvements in lung function and symptoms and reduced the risk of deterioration and treatment failure. However, it comes down to comorbidities and cost. If the patient is already on an anticholinergic medication for another condition, it may be prudent to stick with a LABA and SABA. Group E, just like Group B, LABA-LAMA combination with co-prescription of a rescue inhaler is strongly preferred. Consider an inhaled corticosteroid if the patient is still symptomatic. We know that the addition of an inhaled corticosteroid increases the risk of pneumonia for COPD patients. There is a trade-off. Plus, if there is not much airway reserve left, an inhaled corticosteroid may not offer much benefit. The GOLD guidelines do recommend drawing a serum eosinophil count. Eosinophils are part of our immune system, play a role in asthma, allergies, and eczema. The effect of the inhaled corticosteroid on the COPD exacerbation prevention is correlated to the blood eosinophil count. But if the patient has a low eosinophil count and remains symptomatic despite LABA-LAMA therapy, try the inhaled corticosteroid, just with the understanding you might get some symptomatic relief, but there will be an increased risk for pneumonia. And here you have the CAT and the modified dyspnea scale. I do encourage you to use these. These are good subjective questioning. Naomi is 70. She has a chronic cough. She's a current smoker. Been smoking since she was 20. Let's look at her flow loop. She has deep concavity. Notice how short it is, how concave it is. What does that tell you? Obstruction. Is the FEV1 FVC ratio less than 70%? Yes, it is. She's at 40, pre-bronchodilator. Is there a change post-bronchodilator? No. FEV1, 6%, FVC, 5%. That is not significant. She has COPD. Her FEV1 post-bronchodilator of 37% places her in severe stage E. We would also want to assess her CAT score and modified dyspnea scale to help guide treatment. We'll just do a few more. A 33-year-old woman with 2 to 3 months of shortness of breath and fatigue. She denies smoking. Let's look at her flow loop. We only have the expiratory portion. She has decreased volume and it's tall and peaked. So what does decreased volume, tall and peaked with an absence of concavity tell you? That is probably restricted, but let's look at her chart. Is her FEV1 FVC ratio less than 70%? No. She's at 89%. She does not have obstructive lung disease. Is the FVC less than 80? Yes, the FVC is 58%. She is finding suggestive of restrictive lung disease. So if not already done, we'd want to do a chest x-ray, probably a CT scan, and then we'd want to evaluate for underlying causes. Let's go over the differential for restrictive lung disease, starting with extrinsic. Chest wall deformity. Well, that would be obvious. Does she have severe kyphosis or scoliosis? Well, we have to evaluate her spine. Run your fingers down her spine. Neuromuscular. Does she have weakness, paresthesia, visual changes? We would perform a full neuro exam. What about respiratory center depression? We would want to do a medication review. Is she on narcotics, benzos, alcohol? Severe obesity or congestive heart failure. Now, she really doesn't fit the bill for congestive heart failure. She's pretty young. But if you had concern, you could draw a brain natriuretic peptide. What about intrinsic? Well, what is her occupation? Is she exposed to asbestos? Autoimmune disease. She's 33, she's a woman, and she is fatigued. What's the number one sign and symptom of autoimmune disease? Fatigue. So that jumps right to the top of the list. With lupus, we could draw serum ANA. We would definitely want to consider ANCA vasculitis. Anytime you have a patient who has obstructive lung disease and it's hard to treat and your spider sense is going off, in the back of your mind, be thinking ANCA vasculitis. That's outside the scope of this class, but this would be restrictive lung disease. 64-year-old guy, Solomon, presents with complaints of dry cough, shortness of breath, and shortness of breath when he's laying down. Quit smoking 3 years ago, but he has a 30-pack year history. Flow loop inspiration. Notice on the expiratory phase, we have a narrowing, a narrowed peakness. There is also some mild concavity. But it is peaked, it is tall, it is narrow. That is suggestive of restrictive. His inspiratory looks pretty good for restrictive. So that kind of suggests restrictive, but there is concavity. Let's look at his chart. FEV1 FVC is above 70%. So we're not dealing with obstructive. FVC is less than 80%, so we are dealing with restrictive lung disease. What do his other symptoms lead you toward? Probably congestive heart failure. We would go through the differentials just like we did with the previous patient. But I'd order a BNP on this guy and look for peripheral edema. Mary, she's 32. She doesn't smoke, but she's short of breath. Look at that flow loop. Just looking at the flow loop, what does that tell you? She has decreased inspiration, she has decreased expiration, she has obstruction. Now, if we would just have her chart, let's say we didn't have the flow loop, we just have her chart. Look at her FEV1 FVC, it's less than 70. We don't have post-bronchodilator on her, but just for FEV1 FVC ratio less than 70, we would probably diagnose her, correctly so, with obstructive lung disease. But when we get her flow loop, we see she doesn't have obstructive lung disease at all. She has airway obstruction. So what would we do for Mary? Well, we do a chest x-ray. If we haven't already, we would do a CT scan, but start with the chest x-ray. We would feel her thyroid. She may have a goiter. She may have thyroid cancer that is blocking her airway. We'd want to draw a TSH, probably a free T4, and then consider an EGD. But that's not a good diagnosis, and that just shows why the flow loop can help. It's not everything, but it can certainly help.